from this equal. So John, welcome.
Hi, thank you very much, Ronnie. Hello, everyone. I have the pleasure and privilege to know a couple of people on this call, but lots of new names. So I'll keep this short and sharp. Today I'm going to talk about efforts to develop a shared knowledge base about analytics in health. I imagine all of us have come across really useful nuggets of insight or useful tools and links. And it's often not that easy to have visibility about what's going on in different parts of a sector, even regionally, let alone sort of nationally or internationally. I'll try and keep this to not much more than 10 minutes to work back a bit of time. If I just introduce myself, would probably be a good idea. My name's John Kellis, and I've been on my contract with a local health partnership. I've been an innovation and community engagement consultant, rolling contracts for about 6 years, been involved in supporting collaborative health tech events, sort of different hackathons, and I've been contracted with the local council and helped them make an Our Data program. I've done some community development stuff nationally on AI in 2017 and 18. I used to work for a health AI chatbot. I've got an MSc in community education, but I came into the world of sort of data and tech and lightly analytics through my work on data visualization and data modeling tools. Through my work with the Bristol Health Partners, which is a local strategic partnership that brings together the local council, the 2 universities, 3 healthcare trusts, 3 healthcare trusts and now the combined clinical commissioning group, there have been a range of advancing analytics endeavours over the last few years. I was part of the local digital roadmap workshops in 2016, and regionally we've had an information engine workshop, advancing analytics, and AI workshop, collaborative analytics workshop that I've been part of the design and delivery of. I think it makes sense if I just share my screen, because today I'm going to be presenting the emergent open analytics resource base. Through thinking how to support local analysts in Bristol in 2019, in advance of a workshop, colleague Sophie Taysom and I developed a Google document that contained links to useful policy documents, live sort of tools, a few GitHub links, links to training, etc. And over the last sort of year or so, we've developed that knowledge base a bit, and over the last few months been exploring how to establish an appropriate partnership with key organizations who could support the development of an ecosystem for sharing knowledge. And of course, AphA is sort of key in supporting analysts, and also the Health Foundation are leaders in the field. And what you're looking at now, as well as your lovely faces, if you're seeing that there, is a Google document which contains a set of sections, and in each section there's a range of links. If I just pause before going through that, just to flick over to the Corona Tech Handbook. Colleagues may have seen this Coronavirus Tech Handbook develop earlier this year. It was quite an amazing thing to watch, really. In sort of April, there were often 100 people in just an introductory document. It's basically a collaboratively developed Google document that has an overview index page and then links to numerous subset pages that organizes a very large knowledge base that proved useful to hundreds, thousands of people through particularly the beginning phases of coronavirus. And this model, unfortunately, the Corona Tech Handbook has is just going through a revamp at the moment. So many of the links aren't working right now, but each of these sort of list items had a document associated with it. So it was actually a massive knowledge base that was developed through community engagement and community contribution and moderation. So what we have here in this sort of 20-page document is the beginnings of a well-organized, I mean, how well-organized it is, it will be subjective, but there is a structure to kick off bringing together different people and organizations' insights into what is currently used or useful in analytics in health and care. And what started off as a local initiative quite quickly pulled into scope a broader geographical area. And through the AphA board, it has been agreed that there will be a partnership approach to developing this knowledge base. And the Health Foundation has agreed to support through collaboration with the document. Of course, the Health Foundation has its AAA project, and there is a plan that has emerged sort of based on some draft terms of reference for a working group, for there to be 4 meetings over the next year, bringing together interested parties who are up for doing a little bit of community volunteer moderation to make sure that the appropriate information is in this knowledge base. So I don't think I have time really to go through. If I just share the link, what is the chat channel? So I've just put the link to the document in the channel. Originally it was bit.ly/BNSSG analytics resources for the local STP, which is Bristol, North Somerset and South Gloucestershire. I've created a new link, resources for analytics, bit.ly/resources for analytics. And there are, the protocol in this document is that anyone can add a comment, and then only approved people can absorb that comment into the body of the document. And through having a light touch engagement ask over the next year or so, with these 4 quarterly meetings for a sort of couple of hours, plus the ask of a bit of extra moderation time. And hopefully that, if I just quickly sort of scan through, so there's some COVID specific resources, key policy documents, there's some local, this is currently local to BNSSG. I should have changed that. Over the last couple of months, I've paused on developing the content of this, as Ronnie, Ellen and I and others have been discussing how to make sure there's a good foundation, because of course a document like this needs to be updated fairly regularly. There are a range of projects, range of tools, and range of training opportunities, and then a range of fora, and of course AphA is listed. So when this document was set up, it was licensed locally, but I've changed the license. Ronnie, you and I haven't talked about this, but I think it would be appropriate to have the attribution of this document to AphA. I've become a begrudging licensing expert, and through using the Creative Commons framework, the hope is to ensure that this is an open knowledge base and supports the sharing of knowledge rather than creating silos. Ellen and the Health Foundation have agreed to be sharing both retrospective and future documentation and links to tools from the AAA project. And of course, within the AphA membership base, there's an enormous sort of pooled intelligence, not just the projects that members are working on now, but also the projects and tools that members know of. So that's my 10 minutes. I might go on a little bit longer than 10 minutes if I can. I think I had.
Yeah, absolutely. Go for it, John.
Thanks. So let me just check my notes. I mean, there's lots of other stuff I could talk about. I guess maybe just very quickly to mention, there have been efforts to bring together communities interested in sharing insight and tools. There was Data Campfire, for example, and these resources and initiatives are part of a trend that I'm very pleased to see Health Foundation is sort of leading on, open working, so NHSX and others. That there's a strong sort of mandate and ethical compulsion for us to be sharing information that could benefit the practice of colleagues. As well as there being this sort of document containing signposting links, there is also a couple of I closed the other one, a couple of just sort of straight data sets. And over the next year, in a way, this sort of presentation is partly to let you know that this document exists. Hopefully it'll be useful to you. And also, if you do have a couple of moments, please do scan through it and just drop in comments any additional links that you're aware of, and those links will get absorbed in due course. We are also open and would very much like support in terms of being part of a working group. So there's this sort of, the lightest touch thing is just to sort of scan through it, know it exists. And if, say, a junior colleague joins your team, this could be a useful way to help people understand the landscape. If you can just add comments directly into the document, that'd be great. And if anyone thinks that over the next year they might like to join Ronnie, Ellen, myself, and another couple of people in just having 4 meetings over the next year and doing a bit of moderation time, you would be very much welcome to join the community moderation, and there's some sort of posterity that could come with that. Again, I guess the key thing to mention is that this knowledge base is really, I see it as, if it's going to really do its thing, AphA is the right sort of guardian of it, and the Health Foundation is the key sort of collaborating partner, and those sort of foundations are in place. So I'll pause now due to time constraints. Happy to answer questions, and please excuse me if I've been sort of slightly slow or off. I am still in recovery from corona, actually myself. The last sort of 10 days, 2 weeks, I've suffered from it. So thank you.
Thanks, John. That was really useful. And I've been involved in some discussion with John in the past, quite regularly, I suppose, that we really welcome the idea of the analytical community to get involved in a resource in an open source way such as this. So thanks, John, for all the work that you've put in so far, and hopefully our community can get involved. And as John said, this is an open invite to all of our members and everybody else in the analytical field to join in and contribute to this document.
Thanks,
I haven't received any comments. I think that there's a lot of comments or encouragement, John. I think people there who are watching it like that. Can I just ask your permission? Would you be happy for us to add this to our magazine this month so we can reach out to our members?
Yeah, so the way I see it, Sophie, Taysom and I have developed something that was useful locally, and now there's a view to try and sort of support the broader ecosystem, and AphA is the key sort of lead in that. So I think it's sort of coming to the threshold where this is it can be AphA's baby, and I'm very much here to sort of support, but by all means put it in the newsletter.
Thank you, John. That's great. Thank you very much for your time to come and show us this. Anybody watching today, and if you're interested, John and I will also be speaking at the Health Foundation AAA project conference tomorrow. So we'll be around the same thing. So that's great, John. Thank you very much for being with us. So the next person I'm going to invite will be Paul Uren from University Hospital Plymouth NHS Trust. So it would be great to hear from Paul about one of the work that Paul has been doing. So welcome, Paul.
Thank you very much. Hi, everybody. Good morning. I'll attempt to share my screen onto a remote server because my network is terrible. If you could give me the nod that you can see a presentation. Thank you, Bart. Okay. So I thought it won't take too long. I'm going to whiz through this. What I thought I'd do is give some insight into something we've achieved at our hospital, and it could add value to your teams. And I say add value, I think that's the key thing. If we can reduce churn in our teams and information teams, then we can add more value as analysts, which is like the project we saw earlier in the earlier show and tell. That's absolutely critical, and that's something we're desperate to do and we're always striving towards. So I'm Paul, I'm the BI manager at UHP, and I manage all of the BI units. So we've got a very small operational research team, we have an information analyst team, data solutions team of 3 people, and a data quality team of 1 person as well. And with me today is Rob, who's going to speak in a bit. He's very clever developer. He works on our data solutions team. So driving down ad hoc demand, but it's not about driving down the wrong demand. It's about driving down the demand that we don't want to spend time doing. And we really want to add value to that, to our service users, clinicians, whoever that is. So we've had a massive problem for quite a few years. The backlog was building up. People are getting annoyed. The analysts are getting frustrated. They're really working flat out, churning through all of this information. And when it's stuff that doesn't add value, it's demoralizing. So we needed to do something different. So excuse the slides, they're terrible, but I created them in about 4 minutes. So, Simon, who's our principal analyst, is on the call, and he's also our director of pretty things at UHP, and he would be disappointed in me, so I can only apologize, Simon. So yeah, this is what I've had time to do. So what we did is we had Click View, and we had that because our costing team got it as part of a deal with their new costing system a few years back. So we all got a bit of training, and we thought, I'm an advocate for Click, but also, this isn't about the tools we've used. You can use Power BI and Tableau, whatever you want to do this, to do what we've done, to take a little bit of the churn away from the team, or quite a bit of the churn away from the team. So we decided to get a few people training. Lots of the team analysts are very, very good developers as well as analysts. So they all put their hands up and said, I want to do it. So we got them the training, and then no one did it because no one had time, because we were doing all the daily churn. So we had to make a decision on how to change that. And this is a conversation that me and Simon had, and he's here. And Simon's the one going, oh, are you? And I'm the one going, come on, we've got to do something different. And he knew that, of course. But the conversation went a bit like this. I'm going to take an analyst out of your team, and we're going to put them into a data solutions team, because we had 1 data warehouse developer and they had no resilience. And we couldn't employ data warehouse developers. So I wanted to do 2 things: create a data solutions team to do the ClickView work, but also provide more resilience to the data warehousing team. So we took an analyst out of the information team. We had 1 whole-time equivalent vacant in the data warehouse team, and we created a new role called data solutions developer. And Simon said, well, it better bloody work. Of course, because then the team, I've already described, the team are really struggling, and now I'm just going to make them struggle even more. So it may be that those weren't the exact words, but you get my point. So we decided to do that, and then we had dedicated time to spend on ClickView, which was a good thing, but obviously the analyst team is still struggling because we haven't done anything at that point. So what we did to look at that is we reviewed all our historic information requests, ad hoc requests, and we identified 2 massive areas. So not all the information teams across trust cover the income reporting, but we do. And we also did do a lot of clinical audit requests, and they're not difficult requests, but they still take a little bit of time, whether they're 30 minutes or an hour of work. You've got to put them in a template, you've got to tidy your SQL up, you've got to, there's still a little bit of work to do there. So we thought, what can we do with these two big areas of demand on our team? So we sit across the office from a business advice team. They're the accountants who do the work with the service lines. So business advisors or business finance business partners, some people call them. We've got a very close working relationship with them, and they pour demand onto our team. And partly because we sit in the same office as them, and there's loads of them. So that was a massive area of problem and demand on us, especially our contracting analyst and the clinical audit data. So we thought we'll just tackle those two things first. And here is our super developer. Rob didn't know about this either. You're welcome, Rob. So what we did is we employed two people, and Rob's one of them. So he was an analyst in our team, and he applied for the job and he got it. And what Rob's going to do, he's going to take you through the two apps that he created, working with, so obviously from requirements through working closely with the users in the business advice team and the clinical audit team to build up the requirements to deliver them something that would, they wanted everything, but we had to prioritize what we could deliver for them, and that would reduce most of their demand on us. And it helps them. BAs are really, really clever people. They know how to use data. They just didn't have tools to do it. So in ClickView, we've got a few slides that Rob's going to take you through. So over to you, Rob, and he's just going to run you through a couple of the ClickView apps that he's created.
Great, thanks, Paul. Just first of all, I can assure everyone I'm not quite as muscular as that, but I will certainly take it. So the first app I'm going to take you through is the income dashboard, which we've developed. So the screenshots don't really do it justice, unfortunately, but I will try my best to articulate that. So as you can see on the front sheet here, we have two graphs. One at the top is for income, and the one at the bottom is, as you can see, for activity. And then sort of along the bottom of the graphs, we have a table of data, which shows the actual figures and the plan figures. And obviously, just quickly looking at those graphs, you can tell where COVID is hit because there's been a massive dip there in April and May, June, but I won't go into that too much now. So that's our two graphs on the front there. So that's really useful to sort of visualize the income and activity that we've had across the trust. On the left there, we've got a set of filters. They're actually called list boxes in ClickView. So what these allow you to do is click on them and it will drill down to that data. So for example, there we've got specialty, commissioner, pod and local pod. We've got a tab there for specialty, a tab there for coding, and a tab which says other. So specialty is fairly self-explanatory. You just got filters relating to the specialty. Coding, that allows for you to select options such as the diagnoses codes, procedure codes, and clinic codes. And on the other tab, we have filters such as consultant, admitting ward, and discharging ward. So when a user clicks one of those filters, these graphs dynamically adjust. So that's really useful to sort of visualize that. And then in the top right here, we have a master calendar that just allows the user to select a certain time period and compare that. And then bottom left, just quickly take you through a functionality of ClickView. We have a clear all selections button if the user wants to restart their selections. And there's a current selections box in the top left there as well, which just shows users what they've selected. And next slide, please. Thank you. So these sheets in the middle, we've got specialty, consultant, location, HRG, pod, and local pod. They're sort of all carbon copies of each other, but as you can probably tell, they're just split by the different sort of areas. So this table of data here, you can see that it's got plan, actual, and variance. So this is really useful for the business advice team just to tell whether a specialty is above or below plan. And as you can see, I've just blanked out on the left there, the specialty, just for sort of confidentiality purposes. And And once again, you can click the filters on the left, and that will sort of filter through the data and dynamically adjust in the table. So yes, like I said, we've got the same for consultant, the same for location, for example, Derriford and locations we outsource to. We've got HRG, which is really useful just to relay the income picture back to the BA team. Pod, so that's point of delivery, so that would be inpatients, outpatients, ED, for example, and local pod. So that is sort of a more granular point of delivery, basically. Next slide, please. Thank you. And so the last tab for this app is the patient level tab. So as you can see, there's a big table there in the middle. And it says, please narrow your search criteria in order to generate records. So what we didn't want to do was present random patient data in this table. We wanted the business advice team to sort of make their selections first before they were presented with patient data. So what they can do, they can use the filters once again, and that will sort of dynamically adjust the table there. And the really useful thing with this is you can export it to Excel as well. So if a business advisor is in a meeting with a service line manager, for example, they can export that data and take a more in-depth look at it and filter it in Microsoft Excel. And at the top there, you've got the ability to view the income position for certain patients as well. So you've got a box for hospital number and a box for NHS number. So that was sort of identified as an area of high demand. Quite often we would get queries from the business advice team saying how much income has this patient generated, or can I see the activity for this patient? So that's really useful to fulfill those requirements. And I think that's about it for the income app. Like I said, the screenshots don't really do it justice, but so this is the next slide. So this is just an overview of the process that we went through in order to sort of get the income app up and running. So the first stage was socializing the app. So we've got a really good relationship with the business advice team, as Paul said, and they sit just across the way from us. So they would quite often, take advantage of our analysts and of the knowledge that we have. And it was identified, that we would get a lot of queries from them that would turn into ad hoc requests. So to sort of, we came up with the idea of the income app to fulfill those requirements. And what we did is we looked at previous and existing ad hoc requests for information. And we also, we had plenty of meetings to sort of take down the specifications to make sure what we were putting into the app is, what was required. And also I did a bit of work with the lead contract analyst to identify areas of demand. Because obviously she had quite a lot of ad hocs on her task list for the business advice team. So it was a matter of going through those and seeing the sort of high priority areas. The next stage was the development. So building and perfecting the data model in the SQL Server is obviously very important to ensure what you're sort of bringing through onto the front end is accurate and concise, and developing the front end in alignment with specifications. So literally after we had those meetings with the business advice team, I had about 5 or 6 pages to work from and develop the app and perfect it so it would show what was required. And very importantly, validation. So ensuring the data is accurate and matches that of existing income reports. So we have a host of income reports at the moment where we did that were in sort of different mechanisms, sort of Microsoft Excel, and SSRS reports. So it was a matter of matching up the income app to those sources and matching data in the app against ad hoc queries from a business advice team. Yeah. So I sort of talked a bit about that earlier. We had a look at our oh, the screen seems to have gone there. Sorry, 1 second. Oh, there we go.
Sorry.
No worries. So yes, we had a look at ad hoc queries from the business advice team. There were a few users which would come over to us and just hit us with endless queries, what it seemed like. And we sort of made our selections in ClickView using the income app, and we tried to validate that against those ad hoc requests and those queries to the point where we were happy that it all matched up. And lastly, training and support. So it's really important to make sure that the users know how to use the app properly. Otherwise, they might feel a bit alienated or might not know how to use it correctly and might not use it. So in this instance, we offered one-to-one and group training sessions to ensure that the team were comfortable using the app. And going forward, we created an action log to record change requests and additions to the app as well, because it's something that's always ever developing, really. And the more information we can get into it, then the less demand that we have on our analyst team. So that was an overview of our income dashboard. The next app I'm going to talk to you about is the clinical audit tool that Paul touched on briefly. So I'll talk to you about this big table in the middle. So this is just a table of data, essentially. And once again, it requires the user to make selections in the tool in order for the table to generate the data. Once again, this is to satisfy information governance purposes and to make sure we're not just showing any old random patient data. So on the left here, we have the filters: main, specialty, coding, case notes, patient, and other. So specialty, like I said with the income app, is pretty self-explanatory, just allows you to filter by service line. Coding, that allows the user to filter by certain procedure codes and certain diagnosis codes. So that's really useful for when we get clinical audit requests from a consultant or a registrar, for example, that want to look at how many procedures have been performed or how many patients have been diagnosed with a certain diagnosis. We have case notes there. So as part of the clinical audit process, quite often clinical staff are required to review the case notes and sort of extract the case notes from certain areas. So that's useful to know where the case notes are in that instance. Patient, we have patient demographics such as age and gender. And other, we have filters like discharging ward, admitting ward, and consultant as well. So obviously, with the filters, we've tried to take into account as much as possible based on the needs of the clinical audit requesters. Because like I said, you get registrars, consultants, nurse specialists requesting different information. So we've tried to keep that as varied as possible. And then just at the top here, we have a date range box. So quite often the requests will focus on a time period. For example, all discharges in the month of October 2019. And then what we will also request is, can we have the top 100 patients discharged from this ward? So there's a records required little input box there, which you can enter a number into there, click search, and that will then give you the top 100 records. And also the table of data does allow you to export it to Excel once again, so that's really useful for pinging off the information. And then we have some checkboxes on the top right there. So we have primary procedure, primary diagnosis, just discharging episode, and admitting episode. So that's fairly self-explanatory. We have some data at the top there. So it says total spells, total episodes, diagnosis codes, and procedure codes. So those numbers dynamically adjust when you make your selections. For example, when the clinical audit team are using this app, they will make their selections and they can see they've got, I don't know, 500-600 spells relating to their selections. And lastly, at the top there, we've just got an option to exclude or include national data opt-out patients. That's just to comply with that policy, which is being implemented at some point this year, I believe. And there is a bit of blurb there about contacting the clinical coding team for guidance on which codes to use. Because it's important that when the clinical audit team are using this app, they don't select the wrong codes or they don't make assumptions. They need to sort of have a professional advice on which codes are used for which procedures and diagnosis. So that's the clinical audit tool. Next slide, please.
Well, I think I'll jump in just because we're running over time.
Oh, no worries, yeah.
And I'll just get to the end for you. So just to say, Rob followed the same process really and did a lot of brilliant engagement with the team to get the spec right. So I suppose, thanks, Rob. The evidence is here really. Our ad hoc demand did drop off, and you can see the minutes worked on the tasks did so. Clearly wanted to evidence that because people would have shot me down otherwise. Said, well, you haven't proved it. So we did prove that, and I've stopped the chart at March because COVID will have seen a different level of demand probably on information teams like ours in that time. So I suppose the key things to leave you with is it's not just about getting a tool. It's not just about getting the right people in to use that tool and develop it and engage with service lines, but it's also about making the right decisions for your team and the way you're structuring your teams. That's what's really helped us. To all of those things together have helped us push down that type of work and leave the analysts with more time to spend on more complex queries, stuff that will engage them, make them feel more valued in their work, because they're working with clinicians a lot more, they're working with ops managers to try and do that value added work. So that's it. If there's any questions, probably best to stick them in the chat, and I'll unshare and pass back to Ronnie. Thank you.
Thanks, Paul and Rob. Fantastic work. Excellent example of collaboration. And as you say, just kind of creating a space for analysts to do more interesting analytical work. So thank you very much for your time.
Thank you.
So I'm going to invite Emma now. Emma is going to talk to us about professional registration. So Emma is our AphA's Director of Professional Development. Hi, Emma.
Hi, thanks, Ronnie. I'm just going to share my screen. So I'm conscious that we are running a little bit over, so I'm going to try and quickly run through this brief presentation around professional registration, the role of the Professional Development Committee that oversees registration, what that committee's been up to recently, and just a bit of a run through of the application process. Okay. So those of you who were on the annual conference earlier this year will remember this chap, Ben Goldacre, and his call to arms for all analysts within the NHS, with his vision to create a 21st century NHS analytical workforce, to have analysts viewed as essential members of the healthcare workforce, having analytics in health as a known vocation, with clear career pathways for people to join analytics and know that they have a clear development plan, and ultimately looking at how we ensure that our analysts get the development that they need from a professional perspective, and also that professional registration process. So why become professionally registered? So it gives you a really good opportunity to demonstrate your own skills and competencies and your commitment to your career as well, through choosing to become professionally registered. The registration process then provides an external view of your knowledge and your abilities, so enabling that peer validation to take place, and then it provides you back with the evidence that you're trusted to undertake your role, you have the right skills, so it's that license to practice. So where are we now in terms of our professional registrants and that process? So back in 2019, we opened up our 100 pledges process, where 100 of our members pledged to become registered with AphA and ultimately with the Federation of Informatics Professionals. So last year we had our first tranche of registered professionals awarded at our annual conference. We currently have 11 active registrants on the FedIP register, which you can see in that little table there, and we've got probably more than 10 applicants that are currently in process, which includes all the AphA exec board members, and I know we've got Sophie Barton on the call, so she's our latest registrant to go through the process, and she'll be added to that FedIP register that you can see there. So from where we were last year in terms of those 100 pledges, we've still got a lot to do in terms of the process and increasing those numbers. So the Professional Development Committee, which I chair, has tried to address what we perceive to be some of the issues around analysts actually becoming registered. We identified that the application forms were quite sort of cumbersome, so we've revised all our application forms. They're due to be published shortly on the AphA website. We've also made sure that we've got some clear guidance that supports the application process, and we've got some templates that applicants can use for either reflective practice or some of the evidence packs. And we also recognised that we had quite a it was quite a long process to actually get applicants through that process. So we've now caught up and processed all the existing applications that we have. So the work doesn't stop there. So we know that we need to update the web pages on the AphA website around the registration process to include the new forms, and that will take place in the next week or so. We want to put on some virtual forums and webinars so we can really, guide people through the application process. We will be retiring the original forms. So if you were part of that 100 who pledged last year and you have a partially completed form in the old format, then you either need to move over onto the new forms or have your application submitted by the end of the calendar year. We also want to move to a registration cycle, so where we will open the a window for applicants for a month, and then spend 2 months processing those and moving people into registered status, and then opening another window. And that's to support applicants in terms of having a target date to work to, in order to get your application through, and also support the assessors who are reviewing applications, so they're clear what resources is needed from them. But ultimately we want to increase the number of AphA registrants on the FedIP register. So here he is, Lord Kitchener. He generally makes an appearance in slides somewhere within conferences and webinars, but ultimately we need you. So we need our members to step up and apply for registration. So how do you do it? How do you become professionally registered with AphA? Okay, so firstly, you need to determine what your registration level is. So we have 4 levels: practitioner, senior practitioner, advanced and leading practitioner. So generally speaking, a practitioner, you'll be responsible for your own work area. You'll be choosing tools and techniques, based on your skills. As you move into the senior practitioner levels, you'll be maybe recommending tools and techniques that are used within either your own team. And then as you get up to sort of advanced and leading practitioner, if I stick with the sort of tools and techniques standards, then that's where you're either looking at setting tools and techniques and methodologies right across your own organization or your region. So that's sort of trying to understand what the those levels are. So when you've picked your level, review the guidance and understand the application requirements, and then start building your evidence portfolio and fill in the application form that's relevant to the level that you're applying for. So in all of the application levels, you'll need to provide us with a brief CV. So there is a template in the application form now that enables you to do that. And what you're trying to show here to the assessor is what your current roles and skills are, any formal qualifications that you have that are relevant, and how you've ended up in an analytical role through your brief career history. So these are the revised application forms. So there is a section for each standard. At the start of each section is a brief summary of what that standard is looking for, and then it breaks it down into the individual levels. We've included in there what we're looking for from an assessment perspective. Yes, so you've got an indication of what we're expecting. So there's a commentary box where you can give us a brief summary of how you meet that standard. So all that's required is that brief summary. We aren't looking for war and peace, because what's important is providing evidence that backs up that commentary. So you'll see alongside the commentary an area where you can reference any reflective practice and an area where you can reference your evidence. So as part of the work that the PDC have done, we've included some templates for reflective practice. So this is a worked up example here that will be available. So this is using the STAR technique for reflective practice. So what was the situation? What tasks were required? What actions did you take? And what were the results? And what you'll see here on the screen in red are the references back to those standards. So if I jump back a slide, you'll see here, so P1.1, and in the reflective practice, where you think you're meeting that standard is just a reference to that. And that is just a clear pointer to whoever is assessing your application of how you meet those standards. There's also in blue areas where there's evidence attached, and I'll just come on to that now. So next to the reflective practice, there's a column here for evidence, and that's where you can submit either emails that you may have had in terms of recognition of some of your work. You may want to include presentations that you've done, so they can form appendices within your application process. So we've included in the application an evidence matrix as well. So on the left-hand side, you'll see all of the standards that form part of the application, and then you can numerically tag your evidence and also indicate where you've got examples of reflective practice that also evidence those standards. So as a rule, you know, we're probably looking for a minimum of 4 examples of reflective practice, probably no more than 6 within your application form. You can use examples of reflective practice to evidence several of the standards, and in the same way evidence can also be used to support multiple standards, so you don't need a unique piece of evidence for every standard. So when you've completed your application, you are in the yellow box at the top left-hand corner of this slide. And this is how your application then gets processed through the registration sausage machine. So as you can see, we're looking for a 2-month window for an assessor to review your application. If there's any further information that's needed, further evidence or anything that, you know, the assessor wants more information on, there is a month window there to enable the assessor to get in touch with applicants. You know, we want to, you know, make sure that you've provided as much evidence and clarity as you can. And then in that 2-month window after that, the applications will go through the professional development committee for a ultimate decision of whether you are added to the register or not. So that flowchart is just an overview of how the PDC will be processing applications going forward. So that was a real whistle-stop tour. I think I've just about pulled it back in terms of the agenda. Happy to take any questions or pop them in the chat, or my email address is there on screen if you want to drop me a line. So thank you very much, but it would be great to see sort of a surge in applications coming through over the next few months. Thank you.
Thanks, Emma. That's really helpful and clear. Particularly seeing that kind of flow chart gives a real indication of how we'll be managing the process. So that's really helpful. And I would echo with what Emma said. Please do come forward and sign up for the professional registration, because that's what makes us a valued professional. And of course, from an AphA perspective, we will continue to lobby to add or to recognize the analytical profession as a scientific profession. So we will continue to lobby that as part of our board work and part of representing the analytical community. So that just brings us to the close. Thank you, Emma, for managing to give us that 5 minutes of space. That's really, really good of you. So thank you, everyone, for joining. We had some fantastic session today. Some thanks to Laurie, Paul, and Rob in particular for sharing your work. I found that really, really useful. John, thank you for sharing your work, and I will reach out to our community and ask if anyone would like to be involved, being a moderator or to be added to being part of the working group. Please do come forward and let us know, or let John know, and it would be great to have your input. But for all of our community members to get involved in that open source document and use that. I'd also like to say thanks to Ideal Health and thanks, Jonah, for doing the presentation, talking to us about your service offering. And thank you to Val for organizing this event. I know a lot happens behind the schedule to pull this together. And on just the very last thing for me to say, I know a lot going on for all of us, for our organization, for AphA, for everything else. So, and we're also going through a very challenging time. Lockdown 2.0, hopefully not too many more numbers will be added to that. So at an individual level, do look after yourselves, because all that really matters is about your own health and well-being. And we have to look out for each other. And this is what kind of our community as a whole, our analytical community, should benefit from, each other's support. So look after yourself, take care, and we'll speak soon. Thank you for joining.
Thank you. We're going to stay open for a bit if people do want to stay and chat to each other.